Good afternoon, dear colleagues. Let me present my PhD topic, which is about biological effects of materials and prosthetic design on the peri-implant tissues. My name is Péter Tajti. I'm from the Department of Prosthodontics, and my vision is to provide the best treatment for my patients in implant rehabilitation. Therefore, I would like to implement the fully digital workflow in every aspect of it. My specific goals are these two, which I will discuss. First one is about two restoration materials in implant-supported restorations. In prosthodontics, the gold standard material is metalceramics for fixed restorations. They have an excellent survival rate over 5 years as implant-supported single crowns. Later, as digital technologies evolved, and digital dentistry as well, other ceramic materials showed up. And these materials can be processed with CAD/CAM technology, and they result in better, more precise and more aesthetical frameworks, because these frameworks needs to be veneered with other veneering ceramics. The problem with veneering ceramics is the relatively high chipping rate as a technical complication. These could jeopardize the aesthetics and the function of the restoration as well. So they try to eliminate these veneering ceramics to lower the technical complication rates. So this is a new material, monolithic zirconia or full contour zirconia. They have excellent biological effects with no chipping. They have promising aesthetics as well and high accuracy because of the CAD/CAM processing ability. So we would like to investigate the potential benefits when comparing with the gold standard metal ceramic. So the question was how monolithic zirconia perform in the clinical outcomes, and our hypothesis is that they can be a valid alternative to metal ceramics as implant-supported restorations. After the selection process, we've ended up with 4 eligible articles. The first result is about marginal bone loss at 1-year follow-up. This is important because bone gives the stability of the implant and it can determine the success of the implants. Here we can see that there is no significant difference between the two groups. However, we can see a tendency toward zirconia, but this 0.11 millimeters difference is not clinically relevant. The next one is bleeding on probing. Bleeding indicates the soft tissue health and inflammation. And we can see here as well that the results favor monolithic zirconia, but it's not significant statistically nor clinically. The third result is the chipping technical complication. Here we can see that zirconia had significantly less chipping over 1 year. In the second analysis, when we excluded bruxist patients, because there were 1 chipping in monolithic zirconia, but this was because of the bruxism of the patient. So in conclusion, we can say that both restorations were similarly good regarding bone loss, bleeding, and implant survival. And also monolithic zirconia had less chipping, significantly less chipping over 1 year. So our hypothesis was true. Zirconia can be a valid alternative to the gold standard. We only had RCT articles included. This was the first meta-analysis and low statistical heterogeneity. The limitations, we had a low number of studies, unfortunately, with short-term follow-up, and we had some heterogeneity among the included patients. So using this material, this would mean more predictable and more effective restorations with quicker production as well. And the manufacturing is actually could be more cost-effective. and the soft tissue adaptation might be also better. For the future research, we need more studies, of course, with longer follow-ups, and studies should involve more biological outcomes and more homogeneous population. The manuscript is currently under submission. The second topic is about two different prosthetic designs on implants. So, hard and soft tissue stability around the implants is crucial for their long-term success. And after placing the implant into the bone, tissue attachment will form around them, and this causes unavoidable bone loss in the first year. This bone loss will determine the implant success, so it is very important to measure. And this bone loss is influenced by many factors in implant prosthodontics, such as vertical soft tissue thickness, or implant abutment connections, the microgap position, the implant position in the bone, and also some prosthetic components as well, from which we are investigating the abutment height. They can be categorized as short and long abutments, and prospective studies showed that using long abutment, there might be less bone loss around the implants. So we would like to investigate that. Our hypothesis is that implants with long abutments may experience less marginal bone resorption. After the selection, we've ended up with 8 eligible articles. Our first result is the bone loss at the 6 months follow-up. We can see here a significant difference. In the short abutment group, there were significantly more bone loss over the 6 months. We've got also high heterogeneity because of the low number of studies. The next one is at 1 year follow-up, marginal bone loss. Here also we can see a significant difference. However, the difference is less than the 6 months. And also we did a subgroup analysis, placing the abutments after healing in the first one, and placing the abutments immediately at surgery. But there's no difference basically, so we can say that the connection time has no influence or might not have influenced the marginal bone loss. We have bleeding on probing, indicating soft tissue health at 1 year. Here we cannot see a difference. Both of the methods resulted similarly good results. Probing the pocket depth, we only had 2 studies, unfortunately, and we cannot see any significant difference. Both resulted in good results. We can say that using long abutments at short term, there was significantly less bone loss, and longer abutments are favorable treatment options for decreasing the bone loss, and the time of abutment connection may not influence these biological outcomes. We've got 6 RCT articles included, and we also made meta-analysis in the tissue parameters, soft tissue parameters, and abutment connection timing, which is unique. And we only had human studies, not like the previous meta-analysis. The limitations are the short-term follow-up, and we have moderate to high statistical heterogeneity, and also some heterogeneity among the restoration types and implant placement levels. Using longer abutments in the clinic would preserve more bone, would result in more stable tissues and more predictable outcomes. We need more studies, of course, with longer follow-ups, and studies should use uniform implant depths if possible, and uniform prosthesis. The manuscript will be sent to internal review soon. So we would like to finish these projects till May, and thank you for your attention.
Your second study, I mean, actually this makes sense. I mean, that with the shorter abutments, when the secondary kind of contract is not that well built up, then you actually would get, I mean, I'm just speculating that more troubles, more bone loss. But you still have the, I mean, but this is quite fine, because this is an important message, I mean, really for the clinics. I mean, so this is the safer kind of method. But it would still be, I mean, I know that this is not the case, but it would be still good to have a higher sample number. So, I mean, so this is really an area where much more studies are needed, because otherwise just you go after consensus, or the dentists go after consensus, which could be, I mean, very strongly biased.
Yes, thank you for the comment. Actually, we was quite happy that we found 6 RCTs, because in this field it is considered much.
Yeah.
It's many. Yeah.
Okay, very good.
Congratulations, Péter, to your excellent presentation. I have a question regarding your first project. As we know, zirconia can be manufactured not only with milling, but with 3D printing as well now. So did you read anything about that, the crowns, the zirconia crowns, are made with 3D printing process maybe, or they were all milled crowns?
In these studies, all zirconia crowns were milled. As far as I know, printing zirconia is quite new, and we don't have yet data on printed implant-supported restorations from zirconia. Yeah.